All right, we're going. Okay, let's get started. Okay, I'd like to call to meeting this order of the Assembly Public Health and Safety Committee meeting. It is February 4th at 11 o'clock. We are going to start with roll. We have a couple people on the phone, but why don't you go ahead and get us started?
Jared Gerker.
And this is Cameron Perez-Verdia on the phone. Mr. McCormick, are you there?
I'm here, thank you.
Great. And Mr. Johnson, are you there?
I'm here.
Great, thank you. Okay, and then for those on the phone, if you want to get in the queue, just send me a text and I'll add you. And let's jump in. We've got a pretty big agenda today, and just we're going to do a little bit of agenda gymnastics in that we have the municipal attorney is remote today, and I'm going to try to have her come in and do her report around 11:30. So we'll just sort of squeeze that in when that happens. But we're going to start with the Anchorage Police Department. Chief Case, are you ready to go? You just showed up. All right. Got a whole long list here of stuff. That's great. All right. I'll hold you to that. Okay. If you introduce yourself for the record, you can go ahead and get started. Thanks.
Chief Sean Case, Anchorage Police Department. I think I got about 6 or 7 slides. I'll make them relatively brief. You've seen most of these slides already. This is what I'll be covering, some of the recommendations that have taken place through 2024, as well as a policy project that we're working on. I won't go in great deal with this because I've already done that about 6 months ago. But if you take a look, the 2 numbers I want you to pay close attention to is the total number of recommendations. Column number 1 at the bottom, 178, and how many recommendations we have already implemented was 150. So most of the recommendations that have been made so far have been implemented. That is an extremely fast pace at an organization of our size. And we will have here in the next month or so the final set of recommendations that will be coming our way out of 21CP, which is the project that we're working on that the mayor asked us to do in connection with the municipal attorney's office. So we'll go from 178 recommendations to whatever they have and add to that.
Great. I want to help take us back for those that might not be familiar. So on the left-hand column, what are all of those?
So the 15-year officer-involved shooting study was the one that we did shortly after I became chief, looking back 15 years and doing analysis of all of the officer-involved shootings that we had for that 15 years to see if there were any recommendations for policy changes, training changes, or equipment changes. Okay. We made that open to the public. The Chris Darcy report is the internal affairs investigation. Chris Darcy was hired for the Easterly Alpha officer-involved shooting, and so he made a handful of recommendations, 11 actually recommendations, when he did his final report. We did a staffing study, which covers nearly all of the rest of them. We just separated up, and there were some patrol recommendations, crime suppression recommendations, detective recommendations, and so on. So that staffing study included a tremendous number of recommendations because it wasn't just solely about how do we staff the department. There was a lot of other recommendations. The consultants that did that project for us had many years of law enforcement experience, and so they added some best practice recommendations into that document.
Okay.
And all of these are public and posted and available.
So all the reports, the specific recommendations and what was done in relationship to the recommendation is all public. Is that right?
Yes, sir.
Okay.
Yes.
And where can folks find these?
That can be found on our webpage, anchoragepolice.com.
Okay. Yep. Great. Okay. Thanks.
And I may have died. Travis, could you help me out? Next slide, please. This is the policy project. I'll just focus you to the percentage complete over there near the right-hand side. All of the green dots are good. That means we're making progress. We're 32% through this policy project. There are 10 sections to the policy manual. 2 of them have been completely implemented already. Section 3, the one that we're working through right now, that is all of our use of force policies, canine policy, firearms policy, pursuit policy. So all of those high-risk policies that have to do in and around the area of use of force. Those have all been completed. we're going to release those all at the same time with our employees so they can get trained kind of from top to bottom on those policies, whereas generally we release them one at a time. So we will probably be releasing or training our employees and implementing Section 3 all at one time in probably April timeframe, but we're still continuing the project. So I think 6 months ago when I gave you an update on this project, we were like 3% complete. So we're moving along.
And this is the completion of the redrafting or the creation of the policies, not the implementation of them. Is that right?
So this is both. So if you see like Section 1 and Section 2 where it says 100% complete, that means those policies are in practice and the employees are operating under those policies.
Okay.
So yeah, we're implementing them and going live with them as we develop them, put them through mini legal, train our employees on them, and then the employees sign them and they're active.
I see.
One thing I will add, because I know it's of interest to many of the members, with the exception of Section 3, we are going to maintain our current policy online policies active. It becomes very challenging. These aren't one-to-ones a lot of times. So what you'll see is our old manual staying online. We'll create a carve out for Section 3 because use of force policies are of high interest in the public. And then once we complete the implementation, we'll take down all those old policies and put all these new ones up. So we're going to have a little moment of influx that's going to take, but there's really no better way to do it because the public will be very confused if we have two policies that sound kind of the same, but there's some nuanced differences. And so we're just kind of erring on the side of addressing the high risk, high liability of public interest policies first.
Thanks.
I'm working again. Okay, staffing. So we use 2011 as our benchmark, just in terms of where we're at and what our progress is and the speed at which we're doing. And so that's what you see right there on top. January 2022 of 2026 or January 22nd of 2026. You look that we have 425 authorized employees. That 84 vacancy, that is subtracting the box that you see below, which is 49 people in training. So right now we have roughly about 35 actual vacancies. It's just those 49 employees in training they're not answering calls for service. And if you look at what that compares of over a decade ago when we really started increasing our staffing, that's what 2011 really represents, is when we started hiring a lot of employees. We are catching up to that time frame when we were having a lot of full academies back to back to back and having really not a problem with recruiting. And we're increasing our staffing numbers. This graph looks at 2021 to 2025 in terms of how many non-sworn and sworn employees that we have. And if you look at the net gain, net loss at the bottom, which is the highest numbers of interest, you can see that 21, 22, both sworn and non-sworn employees, we were losing employees. 2023, we continue to lose non-sworn employees at minus 18 for 2023. Started getting net gain on non-sworns, which is great. 2024 last year, 16 sworn positions we lost. Again, not sworn positions, employees. So 2025 was the first year that we had a net gain of officers at a plus 17. We see that trend continuing. I will show you here in a little bit how many applicants we have for the June Academy, but we will see that trend continue. This last slide compares essentially our first staffing report that we had after the new administration took over. You can see we had 62 vacancies when this administration took over. The goal by June of 2026 was to reduce those vacancies by 50%. And you can see January, we're almost there. So we will well exceed that 50% reduction in vacancies by June of 2026. So we're ahead of schedule.
Just for the record, we've been joined by Ms. Baldwin-Day, Ms. Silvers, and Ms. Frawley. Thanks.
Last couple of slides on recruiting to continue on. If you take a look at this graph, this looks at the retention of our recruits. Most are very interested in the amount of dollars we spend on training our recruits. And it really is not super helpful if 50% of them don't make it through the process. And if you look all the way to the right-hand side where you have a 67, a 91, a 77, and a string of 100s, what that tells you is that we're getting better and better about retaining our employees once they get through the process and in the academy and in FTO compared to what we have done in previous years. So our retention rate is going up. We generally average about 38 positions or sworn employees that leave the department in a year. That's retirements, people that just leave, go to another job, people that drop out of the academy or drop out of field training. 2026, I think, is going to be our first year where we're shooting to come below that. We think we've got some things in place to increase retention by a little bit.
Yeah, I have a question for you, Ms. Baldwin.
Would you repeat that number, the annual average attrition number? Overall?
About 38.
38 people. Okay.
Yeah. So if you think we have 28 recruit academies, and when you have approximately 15 recruits in an academy that we had for about 5 years there, we're upside down every single year. So recruit demographics. This is something I get asked about quite frequently, so I appreciate HR pulling some of these numbers together, so it makes it a little easier to answer these questions. But percent hired over on the right-hand column, and then the race and gender of the applicant on the left-hand side. You can see our overall hire rate across the board, regardless of race and gender, is about 9% at the bottom right-hand corner. And you can see that which races outperform that 9% and which are underperforming those 9% or that 9%. But all in all, we're making progress here. I'm happy with the progress. You go back to like 2019, 2020, there was a lot of zeros over on the right-hand side. So that is a pretty substantial difference from I believe it was the 2020 report that was put out with HR. And I believe this is my last slide that I have for you. Important number here is middle column, very last number, 533 were the number of applicants for the academy that's going to start in June, which we refer to as 26-1. We have not been above 300 applicants since 2023 for a recruiting class. And for the academy that's in session right now, we're at 329 applicants. And for the June academy, we're at 533 applicants. So at that rate, and our 9% fill rate, you can see that that's going to put us over 35 recruits for the academy. I've mentioned before that 28 recruits is considered a full academy. However, we are going to take all of the qualified applicants. So if they are in that band of acceptable to be police officers through the screening process, and that puts us at 35 or 36 people in the academy, we will figure out a way to get it done. When you have approximately 50 officers that are in training, the public becomes very impatient waiting for those 50 officers to contribute to responding to calls for service. And so anything we can do to appropriately increase the rate at which we're training our officers, we're going to take advantage of that. And, if we have to have an academy of 35, we'll figure out how to get that done and still maintain the training standards that we have.
Great. Actually, just pause for a second. I have a question for you from Ms. Brawley.
Yeah, thank you. And sorry for missing the very beginning. I'm curious, I know, and this is all good news. Stepping back from that, I'm curious, we talk a lot about kind of comparing ourselves to other cities. I know it's been said many times that even with the maximum, like if every single position was filled, that we still wouldn't have the number of officers that's typical for a city of our size. But I'm curious, and this would be a follow-up. I'm curious what that looks like in terms of population, because that's usually how we compare cities of our population. But I'm also curious about geography, and maybe that's not a way that's typically measured. But I just think about, and I know we've had conversations many times, the amount of hours that our police officers spend driving in the car because our city is so dang spread out. And I mean, that's it has an operational impact at some point. And when we can't change the footprint of the city, and I'm not suggesting that we just keep increasing the number of officers forever to drive around more, but I'm just curious if there's any comparisons to think about as a benchmark as we look long-term, because I know obviously people want police. We have talked about how we need more officers to be able to fully staff a city of this size, but I would love to know how that compares in geography. And maybe it's even looking at something like a county sheriff, because we're also a county. And so anyway, I know that's not a question you can answer right now, but I'm curious if you have any comparisons now, and if we could follow up on that. Thanks.
Yes, ma'am, and I can answer your question. So not an exact science. There are different benchmarks that are put out, different numbers of officer per 1,000 residents is kind of how it's done, and that number varies. But if you look at Anchorage's geographical footprint, the size of the city, and then services that we provide, we're in the range of somewhere between 600 and 650 sworn officers to meet the demands of the city and the services. And one of the real challenges of comparing ourselves to another jurisdiction, obviously you mentioned it is the geographical footprint, but the other thing is the number of services that we provide to the public. And I just briefed my staff this morning and talking about the vision and how the majority of the police work that we do at the Anchorage Police Department has no connection whatsoever to enforcing a law or putting someone in jail, even writing a police report. It may shock you, but the average cop that works the street writes about 1.5 police reports a day, and they're responding to nearly 20 calls for service. That means there's a lot of work we're doing that's far outside of the enforcement role, not to mention all the expansion and services that we're providing and the new units that we're providing to really address some of the underlying issues that the public really concerns about. So I would argue that we're probably, like, if we really want the police department to be responsive to what the public needs, we're probably in the vicinity of closer to 650 officers. And I realize that number's very, very large, and it comes at a large cost, and we probably will never get there. But just to kind of put that in perspective of kind of what the demand that we have on the police department is.
Yeah, thankful. And thanks for that. And I think, yeah, we're just going to continue having these big picture discussions about service levels. And so I think it's helpful as we move forward, just having a picture like that. So I appreciate that information.
Well, and just to add the role of a community service officer within that as well. And I'm curious about where those numbers fit, but particularly in providing services that is not requiring a sworn officer.
So I'm preparing a 2-year outlook for the administration currently. I'm right in the middle of it, which will be both sworn and non-sworn, where I can tell you where we're going to be in 2 years with some projections. So I'm more than happy eventually to do that for the Public Health and Safety Committee meeting, so you guys can kind of see where we could be at.
Okay, great. I'm looking at the sort of agenda items. This was the progress report. Are you also then going to speak to the other items as well, or was that incorporated in that?
I will.
Okay.
I can do that for you.
Yep, great. And just a heads up, I mentioned before, you may not have been in when I said this, but Eva Gardner, the municipal attorney, is going to kind of jump in at some point. So I may pause you and then have her do a quick little update and then go back to you. Okay, great.
So we are moving forward to implementing all the Real-Time Crime Center and the drones first responders. Those policies have been publicly available, certainly publicly available to this body on a couple of different occasions, and I presented. And it's been through the legal kind of wash multiple times. So those two policies we are moving forward, and we actually kicked off the drones first responder project. That doesn't mean they're active right now. That just means all of the infrastructure that has to take place before we can launch that program. We did it this week. So that program is off and running from an administrative perspective, not an actual drone in the sky. The license plate reader, we are ready to go live with that. We went through the same process with that policy as we did everything else. And I am just slowly progressing forward on that, only because for those of you who are following license plate reader technology and one particular vendor, not the vendor we're using, but one particular vendor out there that has had data that's been sold to outside agencies. And so now some of that information has become more public or been used by agencies it wasn't intended for. And so we're going through our contract again with a fine tooth comb and making sure that there are no, there aren't anything that we missed. I just want to make sure that, again, although it hasn't impacted our vendor, that we are where we need to be, because we've clearly focused on right to privacy when it comes to license plate readers. And so we're just a little bit delayed on that one, but I want to make sure we make sure any loose ends are tied up before we move forward on it.
Okay.
And the last update, retail theft unit, that unit is still moving strong. We have well over 130 cases that we are actively tracking, that we've made arrests that are moving through the criminal justice system. We have another approximate 40 cases that are felony related cases on top of those 128 that we're tracking through the state system to see if those felony retail theft cases are being moved forward. So that process obviously takes a little bit of time, but a couple of months down the road, we'll be able to kind of add the full picture from start to finish. So it won't be just arrests, and it won't be just calls for service, it'll be like what happened with those arrests. What I can say is we're getting preliminary data from that retail detail that has told us that the calls for service and reports generated are reduced, or calls for service at our targeted locations have reduced by 15%. And the reports that officers have to come and take at these locations has been reduced by 28%. So even though we're making all these arrests, we are still reducing the overall footprint that law enforcement has to spend at these locations. So we will continue to expand the program. We are formerly, we're going to call it the misdemeanor follow-up unit, because retail theft may change and we may need to focus on something else, but we'll have 4 officers. Now we have 2. We'll expand it to 4. So, you think about those misdemeanor crimes that they fall through the cracks because, officers are having to do all the follow-up on it, and they're also handing calls for service. So we'll create a 4 officer unit that will be dedicated to doing misdemeanor follow-up. And for right now, they'll be doing misdemeanor follow-up on retail theft.
Have you, I'm assuming you have, but have you had focus groups or meetings with owners or managers of retail? Has that been part of your process, is really
So right now,
meeting with them and talking with them?
We've done that with their loss prevention. So we have a monthly meeting with the loss prevention. Off the top of my head, I can't remember what that's up, but we fill the room at headquarters, the downstairs room. So we started with those loss prevention officers. It's really about sharing data. And this is kind of technology as well as retail theft, just to kind of, well, it's because I'm something I'm proud of. So I'm going to talk about it. The Aura technology that I've mentioned before, which is, again, as a reminder, it's the technology that's for retailers. It was designed for them. And we've entered in an agreement with Axon that we convert that to also a data sharing between retailers and law enforcement. And we are the first department in the country to do this. And now we have, I think we're up to 9 or 10 national chain retailers that have added Aura to their use of technology so they can share data. We have one national chain that actually told us they joined Aura because of some of the things that we're doing in Anchorage. So, when I say that I want Anchorage to be the most technologically advanced department of the country, I think we're going there when we're testing new products and expanding new products and having retailers that are joining things like Aura. So something to be proud of, something that's going to make a change when it comes to retail theft and other things. And we really do handle it differently than any other place in the country.
I have Eva Gardner on the line, but I want to just check if there's any questions for the chief before we let him go. Nope. Okay. Thanks, Chief, for being here. Miss Gardner, are you on the phone?
Yes, I am. Thank you.
Great. We're going to move over to you for your update on State of Alaska Public Safety Partnership. You can go ahead.
Sure. Thank you. And I think there was an article in the news recently on the retail theft portion of it. I'm getting some feedback.
Ms. Gardner, you are breaking up. Let me pause you for a second, see if we can solve that problem. Why don't you start again? Because you're breaking up pretty good.
Is this better?
So far.
Can you hear me?
Yep, go ahead.
So State of Alaska, we did enter into just an understanding with them about how to best share and coordinate resources. And as I've reported before, that has 4 components: retail theft, and using enjoyment of public spaces, drug crime coordination, and domestic violence, sex assault, violent crime. So we are making progress on all of those. I think the retail theft one is the one that is the most up and running. Thanks in large part to APs had already done a lot of the groundwork on that. But we do have 2 of our prosecutors designated to prosecute felony theft, and they're working with the state on those. And then on the quality voice one, we have designated a state prosecutor to help us with some of those enforcements while retaining oversight and control over cases. And all charges do have to be referred from APD to the state. And then on the other 2, we have some meetings in the works to talk about how to better coordinate on those. And I do want to say also separately, we're really happy that it's here with me to say that the DV unit, the domestic violence unit in the municipal prosecutor's office, is officially back up and running. It had disintegrated around 2020, 2024. And we're really pleased to have been able to get to the staffing level and the level of experience. We're now able to split that back out. So we are looking forward to an increased specialization and focus on DV crime. Again, and this partnership with the state will really enable us to work with them to make sure that cases don't slip through the cracks in our split misdemeanor felony system. Those are my updates, and mainly I'm here to answer any questions members may have. I know there's been some news coverage of this issue.
Thank you, Ms. Gardner. I have a question for you from Ms. Baldwin Day.
Thank you, Ms. Gardner. So I didn't catch, I caught retail theft and DV. What are the other two areas of collaboration?
Coordination on drug crime enforcement of a strategy for drug interdiction, as well as quality of life-based issues.
Say that last one again. I missed it.
Sure. I think the term issues affecting use and enjoyment of public space.
Did you get that?
And to explain what that is, we're still
Use and enjoyment of public
It's-
spaces.
yes.
Okay.
We're still figuring out exactly that piece of it where the municipality but then it used to do.
Got it. Got it.
But we're appreciative.
All right. Yeah. Yeah. I think we got it. Do you have any other questions? Yeah. Yeah. Thank you, Ms. Gardner. I appreciate the update. I think we got most of it, but if there's questions, we'll follow up with you afterwards.
Thank you, and sorry for the poor sound quality.
All right. Thanks very much. Okay. All right, folks, let's move on to the Anchorage Fire Department. You guys like that to come up? All right, welcome. Share your names for the record, please, and you can begin.
Ben Lewis, I'm Assistant Chief with the Anchorage Fire Department.
Dr. Jennifer Pierce. I am Clinical Supervisor of the Mobile Integrated Health Program at the Anchorage Fire Department.
We just wanted to share with you this upcoming program launch of something we've been talking about for a long time. I think if you recall, probably about a year ago, we presented this really convoluted and busy slide to this group and just want to report on some progress that we've made. So you can see, the person on the left with the lightning bolt just represents to us someone in a crisis or an emergency, and they access the emergency system through 911. And previously, a couple of years ago, our only options were to send an ambulance and a fire truck. And we've since added the mobile crisis team as another option. You can see like there's lines that lead to the hospital, and it's kind of bi-directional with MCT in the hospital, not bi-directional between the hospital and EMS. Now we've added this other component, which is our core team that launched in January. Its focus is on three distinct areas, which are, I guess they work together. They interface nicely, which is the high utilizer program, a medication-assisted therapy treatment program, and our vulnerable patient program. The core team went in service at the beginning of January. They've been focusing on the vulnerable adult population as well as the high utilizers of the system. And I'm happy to say in March, we're going to launch the last branch of it, which is the medication-assisted treatment program. You can go to the next slide. So we've been tracking a lot of data on our opioid response and try to get a handle on it. We've actually updated some of this data, and it's reflected in the last bullet point in the middle column there, which is we had a new reporting platform that we launched to our folks in the beginning of 2025. And within it, we had some required submissions of whether the impression of the provider was that the call in some way related to either an opiate or a drug problem. So that may not be the direct issue, but it was related in some way. And that resulted in about 8% of all of our transports to the hospital had some association that the provider felt was connected enough to select the box within the report. So that confirmed to us a problem that we kind of knew existed. And I'm actually going to turn the floor over to Dr. Pierce to talk about our solution to that problem.
If you can scroll to the next slide. Thank you. So what we're going to start doing in March is rolling out our medication-assisted treatments. That is going to be sublingual buprenorphine that we'll be able to provide in the field to individuals in the community in real time. What we're going to be doing is responding to calls that come in as someone who is experiencing an overdose and maybe have they been provided Narcan through the Hope Kit in the community, or other people around them have provided it, and we'll start asking them if they're interested in having that medication right there. We've been working on is, if you see the brochures in front of you, we created brochures to provide information to the public about sublingual buprenorphine and how safe it is, what to expect. And on the back, you can see our stakeholders who we've been working with in creating a streamline into getting them connected to treatment very quickly. And so when we're looking at who is eligible for this, we looked at the FDA guidelines and evidence-based practice. I also traveled down to San Antonio and Seattle fire departments who have some similar programs already going and have had some great success with it. And so those are why we have the guidelines the way they are. Anyone experiencing any withdrawal symptoms, 16 years or older, and as long as they haven't had methadone in the past 72 hours, if they had methadone in the past 72 hours, we don't want to launch them into what we call precipitated withdrawal. So we actually just make them sicker. So that's why we have those guidelines. And our goal is to always connect individuals to long-term community providers in the end. We'll also be doing follow-ups and outreaches to individuals who maybe we don't make it to. Because right now the team's only Tuesday through Friday, 8 to 6 p.m. And so through the system, like Chief Lewis had mentioned, where the image trend documentation identifies if an individual had an opioid overdose or the call was related to opioids, it'll be flagged and it'll get sent to us. So every Tuesday morning, we'll be looking through those calls that we missed and try to outreach those individuals to see if they're interested in help or treatment and getting connected as well.
And I have one more thing to add. Right now, this program is 100% grant funded, grant we got from the state. I think we're open to any questions if there are any.
Great. Yes, Ms. Baldwin.
Hey, thank you all so much for being here. I wanted to back up just a moment. When the tracking that you started doing to sort of understand what percentage of calls for service had a drug use or an opioid use component, when did you start doing that?
January 1st, actually at midnight, 2025. That's when we launched our new program.
So essentially, we have a year's worth of
We
data.
have a solid year's worth of data.
Excellent. And would you repeat the percentage of calls for service that pertain to opioid use?
This wasn't calls for service, it was transports. So we have,
Thank you.
we have a lot more calls for service and transports. We have, I think in 2025, you've got about 25,000 transports-ish, give or take a couple thousand. 8% of those had one of the selected options associated with opioid or drug.
Okay, thank you. That's helpful. And then the intent here is to intervene and to offer a bridge to hopefully some kind of treatment, something that's longer term. Is this something that you anticipate will also be sort of like a repeat engagement with the same folks who might decline connection to other services, but would continue to use core team services in this way?
I think every situation is going to be different. I do believe we'll have to probably set some boundaries here and there, because what our goal is to help them in the moment and to bridge them to full-time care. This is something the same question I asked San Antonio Fire Department is, how do you handle this? And so I think it's important to reach across to other fire departments to ask how they handle those different situations. And they told me it's client by client is how you handle it, and helping the individuals, maybe not wanting help in that moment, but maybe the next time they will be, or the next time. So communicating with them how we can best help them, but we're also not going to always be providing that sublingual buprenorphine over and over again. We have actually met Dr. Conway, Dr. John Van Bransway of the Headquarters Health Department to also work on how do we work together within our systems here within Anchorage.
And lastly, how many people are on the core team?
Currently, it's just myself and a community paramedic.
Small but mighty.
It is.
Great, thank you.
Ms. Barley?
Thanks. I have a, I guess, bigger question. I appreciate the briefing on this. So, and not specific to the kind of opioid response. So we know that there's, I think, a couple crisis stabilization centers getting, but this is kind of back to the general point, which is, where do you take folks? I know that it isn't online now. Can you speculate kind of the impact on your guys' operations when that is open? Like, and I know it's hard to say, right, how many cases would go there versus somewhere else. But I'm just curious, like, what gap it's going to be filling, and if we have any kind of sense of, from your guys' perspective, right, having another location or having something that's not the emergency room.
We've been working closely with South Central Foundation and Providence in trying to figure that out, actually. And so when we are pulling data, we're always looking at how many people do we transport to the hospital. And right now we have about a rate in 2025 of 88% being able to stay in the community without a transport to the hospital. So I would assume that those percents we transferred to the hospital, majority of them would go to the crisis stabilization center. I also believe there's a few more people who would be more willing we'd be more willing to take them to the crisis stabilization center rather than emergency room. We help them stay in the community when, they're kind of in that gray zone. So I have a feeling we'll probably end up going down to 75% staying in the community is my guess. National trends are about 70% stay in the community, with 20% getting transported to a higher level of care.
And I know it's, again, not your project. Do you have a sense of when those might come online? Is it this year? I just don't remember exactly the timeline.
I was told June of this year for South Central Foundation, and the last update I heard from Thea about Providence was October-ish.
Right, yeah, and I think because that's going to be huge, and so it'll be when those things are online after it's been a couple months. I think it'd be definitely helpful to get a picture of not just how those are operating from those providers, but also how, where, and or did it not relieve pressure on our systems? So.
Absolutely.
Mr. Gecko?
Thanks. I really appreciate the work you guys are doing. Just wanted to run something down real quick. You said this is grant funded through this year, and is there funding beyond this year via grant, or is that something the city's going to pick up the tab for?
So the grant actually won't cover the entirety of the year. I think it's up in July, right? So it'll cover up to July. We're hoping to attain, I don't have confirmation of this because it's a new program and it's addressing the community. I think that's targeted by the alcohol tax fund to hopefully that fills the gap from July to the end of the year. And then beyond that, I guess we'll have to hopefully get operationally funded after a proof of concept.
Okay. Thank you. I want to go back to just, so, and I'm not going to try to pronounce it, but the medication you're talking about. So you get a call, and this is somebody who is coming down off of and is in sort of withdrawal. Is that the target audience? Okay. And so you go out to the call there, they want the medication. So it's something that they have to ask for and be willing to take, and they take it. Are they able to stay where they are and have the medication? Is that correct? Okay. So that the answer is yes. So and the idea is that it reduces the cravings for them to take more of it, take more of the drug that they were taking. Okay. And so the relationship between them taking this and going to a stabilization center is that they would have a better chance of recovering. So is that the ideal combination? Is take the drug, take this medication, and then be transported to the stabilization center when it's open? Yes. Okay. All right. I just want to make sure I'm walking through this correctly. But somebody who is actively high is not going to take this. Is that right?
Correct. They have to meet so many symptoms of withdrawal to take the medication.
Okay. All right. Okay. I think that gives me a clearer picture. And then what amounts of this are we talking about? How many people do you envision that you would be able to give the medication to?
That's a great question. And that's a lot of the questions we were just talking about yesterday in a meeting is we don't know how many people are going to be willing to take it yet.
Yeah.
So we're very much in the beginning stages of seeing how often it will be provided. When I was in San Antonio, we went to 4 different people and provided it 4 different times within just a few hours. In Seattle, they said they had provided 111 individuals in 1 year to buprenorphine. So it's a wide range. And they did 2 different types of programs, follow-up versus responding in real time. And so here, having a smaller community in San Antonio and Seattle, we're actually going to combine the 2 of them. So we're going to be responding in real time and also following up with individuals and seeing if they're willing to get connected. So at this time, we don't have like a real number, a percentage that people are going to see who are interested in it. A really big part of it is getting it out there to the community so they know that this is a safe medication and that we're here to help and this is what we are doing. Because if we don't get that communication out to the community, no one's going to know to ask for it or they're going to feel really unsure about it. So that's part of it.
There, and I can imagine. So I'm coming down and I'm feeling in crisis because I'm having withdrawal and I hear about this or been told about this and I can call and have someone come out and give me the medication. Is that how that works? Or is there someplace I can go to get the medication?
So right now, because of our limited availability and capacity, it would only be Tuesday through Friday, 8 to 6 p.m. is when we can provide the medication. And hopefully one day we'll keep expanding it and keep allowing more people to provide it within the fire department.
Okay, and it can only be delivered by you. It can't be delivered by others. It couldn't
Only
be
a paramedic.
Only a paramedic. Okay, so there's a potential for there to be locations throughout the city that someone could go to, and knowing that it would be there. Is that an option?
We go to the person.
Okay.
Yeah, so it's about us responding to the person, the right place at the right time.
Gotcha.
I could layer into, this is a proof of concept for us, right? Like Dr. Pierce says, we don't really know how receptive our community is going to be to it, but there's a world where this is just another medication on our ambulances and just a tool in their toolbox when they show up to provide people.
Got it. Okay. Yes, Ms. Baldwin-Day.
Is there a way as you're rolling this out, and I totally appreciate this is a pilot where we're seeing what happens essentially. Is there a way to sort of track, for lack of a better word, just conversions? I mean, people who take the medication and say, yes, I'm ready for something more. I'm ready to get treatment. I'm ready, whatever. Is there a way to track how frequently that occurs during this pilot phase?
Yes, absolutely. One of the great things about our new documentation system is we can create those different data points. And one of the data points we're looking at is successful connection to services.
Great. I don't see any.
Data sharing is one of those sort of perennial questions. How much, if any, of this data, given that it is health-related data, is shareable or can be integrated with the systems that other entities who are engaging in behavioral health and I'm thinking specifically about folks who are interacting with our unhoused neighbors. How is that data, or can that data be shared in some kind of meaningful way, or is this potentially another example of ways that data is siloed from providers and there will need to be some other kind of mechanism for other providers to see interaction with the core team?
That's something that we're always working on gaining is how can we communicate better with other providers. Right now, what we do is we do meet with other providers and we do have conversations and we get those releases of information signed so we can have those communications. it's challenging, absolutely, and something that we're always working towards of how do we continue to do that.
I mean, there's a continuum of care, right? So if we go to the, one of the, either the hospitals or, one of the upcoming stabilization centers, like that information is shared with them. And then internally, our system does track repeat patients. It tracks sort of the history within that. So we'll also know, and the MAT team will know like a history that, our history with them. We won't know necessarily other services history with them, but internally we will.
So are you able to data share inside of like medical records sharing like with a hospital, or is that firewalled from you all?
It's right now it's not bi-directional, but it's one directional. Like we share into their network, into their medical network. They don't share. I mean, I think you've been in meetings where we've talked about Healthy Connect and the state site for like this sort of data sharing platform of medical records. That would probably be the closest thing to what you're describing.
So this information, the MIH and MAT and MCT are sort of hooked in, if you will, in terms of data sharing. There's one directional data sharing where MIH data goes into sort of the, for lack of a better word, like sort of the hospital data, but that doesn't come back. You don't have visibility into that. And then I'm assuming that this is all separate and apart from what's happening in HMIS, that there isn't a bridge there to HMIS. Okay. Thank you. That's helpful.
Yep. I think that's all our questions. Thanks so much, you guys. Okay, next up, the Anchorage Health Department. Would you like to come up, please? Welcome. If you both share your name for the record, and then you can begin.
Great. Kimberly Rash, Anchorage Health Department.
Travis Hedwig, Assistant Dean for the Division of Population Health Sciences at UAA and the College of Health. I'm also the co-director for the Center for Alcohol and Addiction Studies.
All right. So today we have a presentation by Assistant Dean Hedwig. In March of 2025, a contract was signed with UAA to complete a secondary data review and program inventory of existing opioid response work in the United States, with the goal of providing a set of informed recommendations to guide the next steps of the Municipality of Anchorage opioid response work. These recommendations provided by UAA focus on actionable, effective strategies that can be practically applied in the Anchorage community. Working with faculty and an MPH grad student, an inventory and review of efforts was completed and organized based on method, approach, and overall success in implementation. A summary document of those efforts is actually up here on the slide deck here. Is being presented to you today by Assistant Dean Travis Hedwig. After today's overview, the Anchorage Health Department will be sending out a survey through our community partner network focusing on harm reduction and prevention strategies, stigma, and community understanding of the opioid epidemic and access to services. Survey feedback and secondary research will inform the next round of funding allocations of MOA's portion of the opioid funding. Take it away, Trev.
Thank you very much. Did you want to call up the slides, please? Before I even get into it, I wanted to thank the previous presenters for your work in harm reduction and mobile crisis response. That is absolutely part of the effort as a whole as we re-envision what kind of systems level response we need for this most urgent, most pressing public health problem in our state. Right before this meeting this morning, I was at the Alaska Mental Health Trust Authority meeting with some of their project folks. And the expression that was used was that substance use in Alaska is a gnarly problem. I will agree, it is a most gnarly problem, and it's going to require an all hands on deck kind of approach. So for my part, as a university faculty and center director, we seek interprofessional responses to these kinds of problems. Our state necessitates it at this time. I also wanted to thank the Anchorage Health Department for their partnership in this work. MPH student Samantha Ponce, who at the time was leading a opioid response effort in her county in Northern California. She's from Nome, Alaska, and has recently returned and is now serving as a program officer for the trust. So it's really interesting to see that pipeline created so that one of our own can continue to carry the torch for this work. If you want to go ahead and share, please. As was just introduced, this work really began in the summer of 2024. We started with the 2019 Community Needs Assessment that was completed by the Anchorage Health Department, I believe with assistance from the Office of Substance Misuse and Addiction Prevention at the state level. Our charge was to update that document. Since 2019, what had occurred? What's been occurring since the COVID-19 pandemic? And in the intervening years, we had opioid settlement monies that had trickled into the state. So the other thing we did was review the Exhibit E guidelines for how we can spend and utilize that money for opioid mitigation strategies. So it had included an inventory of work that had been completed since that time, interviews with key personnel in public health, public safety, and tribal health, and a review both in Alaska and elsewhere in the United States of the kind of efforts that were being funded with opioid settlement monies. Next slide, please. We basically took the 2019 needs assessment as is and assessed whether or not the goals that had been set still held true. We distilled those results down to 3 primary goals, and we updated and reformulated them along primary, secondary, and tertiary prevention strategies, whereby in public health, thinking of the total social ecology, a lot of times in Alaska, we use the metaphor of the river of public health. What does it look like to go upstream and identify the kinds of ingredients that help people do well? What community factors, what family factors, what individual factors, and how can we do more of those things while at the same time improving access to longer term detox, treatment, and recovery services in a more downstream sense? So we work with both public health and clinical professionals in this work, and we distilled that down to 3 primary goals, addressing stigma and misconceptions around substance use, and in particular, treatment-seeking behavior. This is not just for individuals actively using, but also for community members. How can we destigmatize the ask for help? What does it look like to reduce that initial barrier? I think it was just explained in the last presentation. People need help at the immediate moment that they ask for it. What does it look like to wrap that kind of support and feed that into a broader system of detox treatment and recovery, especially as we look towards what do our systems look like in the next 20, 50 years even, as we have conversations about rural health transformation program monies and other such strategies. Secondly, if we could back up to the last slide. Secondly, we're also looking at our role as a partner in the UAA College of Health is producing the next generation of the workforce. What does that look like? What does it look like in clinical settings? What does it look like in more upstream community settings? And of course, privileging and really prioritizing and amplifying what we see as emerging synergy in the public health and public safety space. You just heard that in the previous presentation. And then lastly, this one is almost a no-brainer, but warrants repeating, expanding access to treatment and long-term recovery services. And I'm pleased to report that we are doing some of those things. And so it's a little bit of what does it look like to do more of those things? What does it look like to diversify those efforts? Because everybody steps into that moment as an individual human being with sets of risk and protective factors that are part of the conversation. Next slide, please. I won't bore you with the details of this, but we did create this as a chart that's available in the document that we'll be distributing. I'm currently working with the Anchorage Health Department on something of a communications plan. Do we want to do this as a series of one-pagers? Is this an opportunity for community health, education, and outreach? What you'll see on this chart, each of the 3 goals are spelled out with primary, secondary, and tertiary prevention strategies attached to each of those goals. Next slide, please. I'll do a little bit more of a deep dive. So for example, thematic priority number 1, addressing stigma and misconceptions surrounding substance use in the most upstream sense. That includes things like continuing to make sure our data systems are shored up, prioritizing evidence-based, non-stigmatizing information on social determinants of health, opioid use disorders for both clinical and non-clinical audiences. And with my public health hat on, what does it mean to invite younger generations into this conversation? There's the old saying in public health, an ounce of prevention is worth a pound of cure. Couldn't be more true in this space. Moving to the right into more secondary prevention strategies. And I'm again pleased to report that some of this work is happening as well, expanding the use of peer recovery coaches, not just in the traditional grassroots sense, which is very important, but also in terms of micro-credentialing. What role can the university play in standardizing curriculum so that working professionals with interests in these areas can take a cluster of classes in the College of Health, perhaps with the Center for Alcohol and Addiction Studies, so that we can be producing cohorts of working professionals that have understanding and experience in not only opioid response, but polysubstance use generally. Then, of course, moving further downstream, it also links to supporting access to stable recovery housing, permanent supportive housing, and many other iterations of what that can look like. So I do appreciate the questions that came out of that related to the housing space and questions of data interoperability that I think we're also poised to work on in partnership with you all. On the bottom, you'll see there's some of the examples. In Alaska, of course, we have Project Hope. Many of you are aware of this. Some of the education around trauma and trauma-informed response that the Alaska Children's Trust is leading on. And through the Rural Health Transformation Program, a statewide effort to begin the process of micro-credentialing around peer support certifications, which I do think is an emerging workforce need. Next slide, please. Moving on to thematic priority number 2, and I just kind of bridged this with workforce, increasing those synergies with our public safety professionals, emergency responders, fire responders, and the police, of course, working very closely hand in hand in both clinical and non-clinical settings, because we require an interprofessional approach. I know that our first responders are burdened, that it's not a matter of asking someone to earn another degree. What could it look like to assemble and scramble interprofessional teams in response to some of these emerging problems? Moving to the secondary prevention tier, strengthening our community-based crisis response. Indeed, this too is happening. We have an integrated behavioral health center that is set to open this year. All kinds of opportunities to begin to build out our mobile crisis response. Partners in Fairbanks, we might invite to this discussion. My understanding is Fairbanks is pretty far along in launching its mobile crisis response. I'm also interested in such things as therapeutic crisis intervention and a number of other models of de-escalation in the context of community policing. Moving further to the right, and I'm once again glad that our partners in the fire response space are working to increase access to medication-assisted treatments, not just one, but a variety of medication-assisted treatments. I was a part of a study with the Anchorage Corrections statewide. We looked at Anchorage Corrections, Highland, and Goose Creek, and we were testing to what extent access to medication-assisted therapy reduces one's risk of recidivism. The short answer is it doesn't. Not without all of the other community ingredients, things like a warm handoff to a community provider, something as simple as having access to a case manager who can remind you of that appointment you have tomorrow and make sure that transportation needs are covered. That is absolutely part of the conversation as well. So yes, it's expanding access to medication-assisted therapies and the knowledge and education around not only use, but post-use supports in the community. Then you can see examples on the bottom. Crisis Now initiative. Again, I want to give a shout out to Fairbanks, which is doing incredible work in this area. So are we. And the Alaska Reentry Partnership, specifically in the area of individuals who have been incarcerated, often on drug-related crimes. What does it mean to support those individuals in community after they've served their sentences? Next slide, please. Thematic priority number 3, expanding access to comprehensive detox treatment and long-term recovery services. I absolutely see each of those 3 instances as separate responses. What does it mean to get somebody stabilized in a detox sense? That's sort of the first piece. Then what does the handoff to treatment look like, whether it's inpatient, outpatient, or some combination of all the above? And then after somebody has successfully completed treatment, what does that long-term recovery support look like? And it must include all 3 of those elements. Bless you. Examples of strategies in the most upstream sense: increasing adoption of screening tools such as ESPERT, screening, brief intervention, and referral to treatment, and other validated screening tools. What does it look like to bring up medical professionals, paraprofessionals, community members that have interest in these kinds of questions through screening technologies? That's the best way to identify and wrap that immediate first tier of support. Secondly, perhaps space for rural health transformation program monies here as well, expanding access to telehealth programs. Literally just had this conversation at the Alaska Mental Health Trust Authority this morning. No matter who you are, no matter what community you live in the state of Alaska, you should never be more than a call away from a professional. Not that we're going to have a heart surgeon in every single community, but there should be a level of response no matter where you are in the state. That needs to be supported. Lastly, supporting employment for individuals in long-term recovery. That could include such things as peer support, but there's also quite a bit of evidence that after somebody is in recovery or served a sentence, that getting them connected to meaningful employment is actually one of the long-term predictors of success. There are others, but that's a big one, and it's one that we can work on. Some examples on the bottom: ANTHC does have a telehealth technology center, and we have the Alaska Health Workforce Coalition that is really doing a lot of work to identify where are the workforce needs and what is our role in the college in meeting those needs. Next slide, please.
Can I pause you just for a second? Actually, I have
Yes,
a
please.
question for you. Ms. Brawley, go ahead.
Yeah, thanks. And I apologize, I'll have to leave in a couple minutes, but I'm just curious. I know there's multiple reasons why people use these substances, right? And I know very publicly there's the story about really moving from prescription drugs to these similar substance that is not legal. Do we have any sense, and I'm sure it's multiple things, but I'm curious, do we have a sense of how much folks who are in this population are there because of physical pain? You know, we know it's a combination of physical pain, emotional trauma, generational trauma, right? There's a long list. But do we have a sense? Because I think, you know, folks get characterized a certain way or it starts recreationally, right? And there's different stories. But I'm just curious, like, is there any sense of kind of how much of it is really pain management, physical pain management?
Great question. I think I'd have to take a look at that. Hard to answer that in macro. I kind of echo the answer from before. Everyone is coming to the table with a slightly different background, and what brings them to that moment is going to vary. I can say right now I'm very concerned about polysubstance use, and that probably represents maybe 5 to 10% of the most serious and chronic forms of use. There are some newer and promising medication-assisted therapies for things like methamphetamine, but what does it look like, that toggling back and forth, which is actually linked to policing as well. Another reason why that conversation needs to be ongoing. It's really hard to answer that in a macro level, but I think it's important to look at each one as an individual person, an individual case-by-case basis. I can say that there are a lot of individuals that are in our correction system that the foot in the door is a drug-related crime. So that has interesting implications for what that handoff looks like back to community. And that's really where a lot of my interest is right now.
Yeah, thanks. Those are fair answers.
Ms. Baldwin-Day, do you have a question?
Yeah, I think on a practical level, you know, this the screening and identification, where exactly do you envision this sort of screening occurring? What are the settings that you have in mind when you talk about
Community
that?
health centers, primary care, nurses, PAs, variety of paraprofessionals, community health aides, the ESPERT screening, brief intervention and referral to treatment or services is a validated screening tool. It's short. So it may just be as simple as convening providers and how to apply it and use it. And then now we're back to data. Once somebody has been identified as at risk, what is the course of treatment from that point forward? That maybe that person who administers SBIRT might not be the person equipped to deliver that service, but it creates an onboarding ramp to that next place. So that's why I considered an upstream strategy. Implementing SBIRT across the board has been a discussion in Alaska for at least 10 years.
So when you say across the board, you're envisioning clinical settings, community health settings, public health nurses, like those kinds of things. I mean, you're envisioning this being applied fairly broadly.
Absolutely.
Okay.
Even law enforcement. I mean, I envision UAA in partnership with some of our clinical programs like UW MedX, physician assistant programs. Couldn't we, I'm just spitballing here, couldn't we use a municipal van, let's say, to assemble interprofessional teams of faculty and students to tour camps, homeless encampments, and do some SBIRT initial triage medical care. We can run down to the library. We can go to Bean's Brother Francis. What could it look like to give students access to this kind of public health practice on the ground? And I think there's all kinds of opportunity for us to continue to collaborate with the Muni on this. I am interested in those vans too.
Thank you. That's helpful. I was trying to wrap my head around, like, what does this look like in real life? And then also, what does it look like in real life? Totally appreciate the comment that, meaningful employment and peer support is critical for folks who are in that sort of long-term recovery stage. How do you square that with just the practical questions of employability for folks who might be coming out of incarceration with some sort of a barrier crime, who might have, it strikes me that that's sort of a perennial question that crosses over from the behavioral health space into sort of our carceral system and the way that works in employment law and all those things. What avenues do you envision opening up that might make this more feasible?
Great question. One is just a community and public education kind of question. That's somebody that, we live in a country of second chances. Somebody that's done their time might come to the table with meaningful skill sets. We could crosswalk the skill sets that, I don't know, a drug pusher brings to the table, and how that might translate into a sales job, for example. I'm playing with that idea. But one of them is a community outreach question. It's not damaged goods. Somebody coming out the other side might actually have a lot to bring to the table, and maybe some assistance needed to help with questions like job readiness. And I also want to be careful about this because I know policy is often linked to employment in ways that could be problematic. In other words, if you don't maintain that job, risk of losing benefits, housing, other things, I think that's something we ought to be particularly careful about. In our study with corrections, what we looked at is like archetypes of success. And what we found was that having a job, any job, was protective. Just like having a family to go to was protective. Having a child and that you were looking forward to reconciling with, stuff like that. So we identified those elements that were most likely to lead to successful outcomes, and employment was absolutely a statistically significant predictor.
Yeah. Was there any, sort of in that realm, was there any conversation with some of our local trades unions about, on ramps into that kind of employment? Has there been some synergy there?
Yes. And this may be like another conversation we have about employment specifically. In addition to my position at the Center for Alcohol and Addiction Studies, I also work at the Center for Human Development, where we train in the National Certificate in Employment Specialist. So our National Certified Employment Specialist, which is a national credential that allows somebody to, for example, build a division of vocational rehabilitation for employment support services. Many of the individuals we're talking about may have co-occurring severe mental illness and substance use disorder, and that employment ramp, to your point, might look a little bit different. That's an area we absolutely can work on.
Yeah, thank you. That's helpful. And I would appreciate a further discussion on that point specifically.
Yeah, we
So,
could do this again. I
Great,
love
thanks.
And
that.
I think there's actually quite a bit more than we could discuss. I'm afraid we're running really short on time. I want to just give you an opportunity. I know you didn't finish all of your, but any other sort of
One slide, we're-
closing comments?
Yeah,
please,
we're
please.
here. The state of Alaska is about to get a $200 million cash infusion. I think there's opportunity through rural health transformation to deepen our statewide workforce, to improve on cross-sector collaboration. We just had a discussion about workforce. What does it mean to support technical assistance needs of providers, to build a community of practice that is quintessentially interprofessional as we lean into these problems? A couple of conversations about data interoperability. Rural health transformation is really an interesting pathway to get there. Could we use AI-assisted data interoperability platforms? Such platforms exist. There are some folks at the statewide EPI work group working on such things right now. And then lastly, I really wanted to communicate that the Center for Alcohol and Addiction Studies is open for business. We want to be a research and evaluation partner to all of you, and we see an absolutely critical role for us in preparing the next generation of the workforce. Really, thank you very much for your time today.
Thank you. Thank you very much for your presentation. Do you want to give a quick update on the next item?
Sure, yeah. So that's a quick update is the micro units. So last night, the agenda item came to you on the consent agenda, the A version. The intent to award to Anchorage Recovery Center. So it will be about within the next 4 weeks. That they spin up the rest of their staffing. We work through the contract piece. They do have to sign a lease with ACDA because as we know, ACDA is running the micro units. And then get people in the door at those units. They have their whole process in place that they will be following as what they do currently. So they're just going to mirror that at the micro units. And they will be heavily connected with the HOPE team, MDOT, as well as our shelter system.
Great. Yes. Mr. Kirker.
Yeah, thank you, Director Ash. I've read some reporting about that they're still vacant. Would you say that you're on schedule, behind schedule, or ahead of schedule on getting those units filled?
I would say we are slightly behind schedule. It took a little bit longer to go through the negotiation process at the health department, so we are a little bit behind schedule. We're hoping that there is some time left with the Visser contractor because the contractor through ACDA, Visser, and the Anchorage Recovery Center have to work together with the health department to do the final punch list of those units.
Okay. All right. Thank you. Appreciate everything you're doing.
Thanks. And before I let you go, just wanted to, in terms of this work, your report, I really appreciate it so much. And I think I'll read through it so I more understand it. The two pieces that stand out to me are the need to sort of have a really comprehensive understanding of the challenge that we face, right? And I'm curious if this does that, if this really helps somebody to go, okay, let's really understand the full nature of the problem, where it came from, where we're at, and why these things are going on. So that's one thing that I feel like is still missing, is something that can be communicated to us and others. And the second piece, particularly because we're a policy making group, I think about it from that lens. And I think about the comments I've heard from, for instance, the Anchorage Police Department that have said, over the last decade, we may have swung too far one way in terms of really focusing on, really taking care of folks and treating people right and taking that sort of thing. And the enforcement was less and less and less and less. And we may have swung, this is just his comment, and maybe we need to swing a little bit more this way. So I wonder in this about where enforcement lies, where policy lies, if there are actually policy changes that have led us to where we are. And maybe there's some shifting back. So I'm curious about both that big picture and where both treatment and prevention and all of the things you're talking about lie, and where enforcement and policy in that lie as well. So I'd love to have a conversation offline about it, and I'd love to actually use some time in this meeting at some point to explore this even more.
Thanks. I mean, in short, I think it does a little bit of both.
Yeah.
It was created with the intent to be a guidance document for you all.
Good.
And it's got a little bit of the history, and I'm happy to follow up at any point. Thank you.
Thank you so much for being here today. Oh, yes, go ahead. Sure.
Yeah, just quickly. So Anchorage Recovery Center will be operating the micro units. And that RFP did also include the Golden Lion event.
Correct.
Correct?
Yes.
Okay, great.
Yes, you did.
I have constituents who will be glad to know that. Thank you.
Yes.
Thanks. And thank you for being here. Great. Amanda, are you here? Oh, wonderful. Come on up.
Could I ask one question?
Oh, yes. Sorry, Mr. McCormick. I did not see you.
Oh, I just wanted to thank Professor Hedwig for the presentation and report, and he was my favorite professor over at UA, so really appreciate it and grateful to see him around.
Keith, I really appreciate you and your perspective, and I'm ready to have that housing conversation.
All right.
Thank you,
Thank you
Keith.
very much. Thank you, Mr. McCormick.
Hi, good afternoon. My name is Amanda Loach. I'm the Office of Emergency Management Director here at the Municipality of Anchorage. I've been asked to give a briefing on the 2025 West Coast storm recovery. There's not very much time to
Oh, you're
cover
okay.
what I need to cover. Recovery from a disaster 7 years later, we're still working on the 2018 earthquake recovery, and this is a very complex disaster. So I think what I'll do is I'll just try to give you a few minutes just to let you know what's going on right now. And then if there's more information you need, we can cover that at another time. So the Office of Emergency Management and other municipal departments are continuing to meet 3 to 5 times a week to work with state and federal and tribal and local volunteer organizations to progress just the short-term initial recovery stages as a host city with the direct impacted Western Alaska communities with a number of evacuees here. Right now, we're working on immediate needs for the short term, shifting evacuees from hotels to temporary housing in our vacant housing that is here available in Anchorage if they choose to settle there for whatever period of time. The peak numbers for the sheltered evacuees here in Anchorage were 172 households representing 682 individuals. And right now, today, the current numbers in our hotels are 80 households with 402 individuals. Those that have transitioned out with state assistance through the programming with the federal and state assistance is 92 households with representing 287 individuals. For planning purposes, the goal is to move everyone out of the hotels and into our open vacant housing here in Anchorage, if they so choose to be there, by March the 1st, moving 15 families a week. For now, the work that we're doing to support unmet needs in the space of that immediate needs recovery is working with teams to fill transportation gaps, furniture, and household supplies as they move into those places. There's also groups that are working on continuing to bring in traditional foods and deliver those traditional foods to the evacuees since they are unable to participate in their regular subsistence work, and also lost all their subsistence food when they moved to Anchorage. As far as next steps goes, they are working on applying for permanent housing programs with the federal government and continuously working with each individual household on helping them with their particular custom designed by their own determination recovery plan, and then preparing for spring. There's a lot of inspections that have to go on with households and infrastructure, and then moving forward with the long-term recovery group. It is likely that there will be a number of evacuees that will not have the opportunity to return by this fall. The issues that we're struggling with as a host city is balancing advocacy with support. Since we are not in the direct impacted communities, but we hold a lot of evacuees within our jurisdiction, and as well have a lot of the resources that can help evacuees with recovery. It's really a balancing act of advocacy and support. Also, the Office of Emergency Management is going through our regular post-response activities, fielding surveys and reporting on the after-action items that we've identified for improvements, identifying strengths and weaknesses, and then pushing forward with an improvement plan, a prioritized improvement plan. We are also working on the response, reimbursement with the state of Alaska, and providing technical assistance for the operations that are occurring here in Anchorage. I'm happy to take questions.
Ms. Baldwin.
Thank you. I'm curious how you would characterize the support and communication with state partners at this point.
So the state is the lead in the response and recovery effort in coordination with the federal government that we interface. Normally, it's very hard for us to gauge because the actual lead, designated lead of disaster response is the impacted community. And so it's hard for us, not being an impacted community, to really understand how the communication is going because we are not a directly impacted community. So it's hard for me to say how the communication is going when we are just a supporting entity.
So they're not communicating directly with you.
No, they're communicating for the purposes of coordination. And so, there's multifaceted teams from voluntary organizations to state, federal, tribal, private citizens, private businesses, et cetera, that are working different aspects of this event. So it's very hard to tell you how the communication is going for the purposes of the impacted communities. But I can tell you from my perspective, there's plenty of meetings happening and lots of reports going out, and we are monitoring those heavily and supporting where we see unmet needs.
Yeah, I think is impacted community, is that a technical definition? Is that a technical designation?
It very much is. So when you go into a disaster process, there's certain communities that were affected directly by the event. So the Western Alaska communities that suffered from the storm, they are considered the directly impacted communities. And though Anchorage has served as a host city and was happy to do that and provided response and recovery support as well, we are not considered an impacted community. And so therefore we cannot, as part of the system, lead any of the response or recovery activities.
That seems really challenging. So, yeah. I think I'd be interested to have further conversation about that. Understanding that we're not directly impacted, but in terms of absorbing a significant number of folks who are refugees from that climate event, it seems like not having more of a leadership role could be really challenging in trying to coordinate among when we're not necessarily the lead as the state is in this situation. So, yeah. And I think a question I've heard from constituents, and I think I know the answer, but I would love to have a more technically complete answer, is how are we paying for this? And what percentage of the funds for this recovery effort, at least the relief effort here locally, is coming from municipal funding versus other funding sources? And are we fronting funds that we will be reimbursed for? What does that picture look like in terms of the financial outlay?
Yep, I'm happy to talk that through with you. It's being discussed in the media as well, and there's appeal processes going on. But for now, we're just supporting with day-to-day activities, day-to-day funds.
I think I'd like to have a longer conversation about that and what that means now versus the activities we were engaging in previously. And that would be, I think, helpful for me to be able to answer constituent questions as they come.
Yep, I'm happy to have that conversation, not only for the now, but for the next time we have a disaster. It's helpful for you to understand all that.
And I just want to verify the numbers that you gave. Originally, it was 172 households and 682 individuals. That's what I got. 172 households, 682 individuals, and then currently it's 80 households and 402 individuals. Is that correct?
Correct. That was the peak numbers in the hotels, but I don't have the exact numbers of how many evacuees have received assistance to get to Anchorage. But the last estimate that I heard was over 800. So, there are they're estimating 15 families that still need to come to Anchorage. So that's why the numbers change over time, is because over the course of the winter, some of the families have been overwhelmed that stayed back in the community, and they are continuing to come into town.
Thanks.
And the other pair of numbers that you shared, 92 households, 287 individuals. Can you repeat what those numbers represent?
Yeah, 92 households and 287 individuals just means that a family may fluctuate from 1 to 15 people in a household. So
sure.
That's just the difference between the number of households and the number of.
What happened?
Yeah,
Say again.
Those are the numbers you said were housed or were moved into some
Oh,
sort
I'm
of
sorry.
stable.
Those that have transitioned out of the hotels into our open housing.
Okay.
And I get those reports daily. So if you guys need updates at any time, please let me know.
Right. Thanks so much for your time today. We appreciate it.
Yep.
We have some time left for public testimony. Looks like we have a couple. If we could set up a few, if we could set up a microphone, please. We're probably going to have to go a little over to accommodate the folks. I think we can get the few folks in. So you'll have 3 minutes to speak. There'll be a timer up on the screen for you, so you know how much time you have. You can share your name for the record, and then you can begin. Yep, you got it.
Joseph Narcomer Brooks, the first veteran of the Air National Guard, archivist, synopsis grandeur, diminished hollyhock, piracy, invasives, slacking panacea, scurvy, arisen, macrocosm befuddlement, dismay, arisen zweebags of zombie befallen, mundane orders of the cosmos. Amen, Yahweh.
Thank you for your testimony, sir. Okay, who'd like to be next? Come on up. Share your name for the record. You'll have 3 minutes.
Oh, shoot. That reminded me of a Robin Williams sketch, Work from Work. Okay, here we go. So, Jamie Lopez, East Anchorage, formerly Coalition, formerly homeless. I was not prepared for that one. Can the Office of Emergency Management run the homeless policy in Anchorage? Seriously? They seem like they've got their act together. But we are a directly impacted community, and there has been a disaster in this town. The question is anybody going to acknowledge it? I've been doing outreach for over a year. You have no ground game, none whatsoever. And what I'm doing is no different than what they do in foreign countries. But you build trust and relationships by going out, not being a threat. You build networks, you leverage those networks, and then you can help people. And then if you help them and you do it reliably, they trust you and they know that you care. And then they're willing to break the cycles. And what I see here is more of the same. Where the core team, I think, maybe a good idea on paper, but it's still based on the telephone response model where maybe, somebody calls, maybe somebody gets help, but it's not proactive engagement. And yeah, so there's that. So Professor Headway, he had some things in his presentation which were good. And I agreed with about 50% of it. But again, part of the point that he hit on was you need people with lived experience to be able to sort of impact and direct this thing. And none of them seem to be employed. and you're not offering to employ people and lift out people out of poverty. And that is part of the issue is you have to get trustworthy, reliable people that actually have been through it to sort of fix the problem, and not the people that are paid consultants that sort of, land jobs that do it that way. And so when he was talking about the types of homeless, I typically break it down into 4 types: mental illness, substance abuse, people who fall into it for any number of reasons, financial, medical, series of events, dominoes that fall. That was me. Class 4, people that have been homeless, or excuse me, people who like the lifestyle, or people who have been failed so many times by so many different people that they essentially give up. They lose hope. They accept the reality of where they are. And that's that. They stop wanting for more. And so sometimes that's because family members fail you. Sometimes that's because the paid outreach people fail you, or people that say that they're going to house you are going to fail you. And so you can be one of those things. You can be all 4 of those things. You could have financial issues, and then get depressed, get the mental illness, and then you turn to drugs as a coping mechanism. And then it becomes a vicious cycle. You end up out in this stuff. And then the people fail you. The people steal from you. They burn your stuff to the ground. And it's the same thing that happens to war veterans. And so, again, the way that you fix this thing, it's not leading with law enforcement or, AMDOT, which is a law enforcement operation with all these things attached, because they realized that they couldn't really get the results that they wanted. The way that you fix it is with people like me. But you have to be willing to pay good people to go out and that are trusted because the stakeholders are out there and you're not bringing them to the table. Thank you very much.
Thanks for being here. Thanks for your testimony. Next up. Oh, well, welcome. You know the deal. Share your name for the record, and you'll have 3 minutes.
Okay. Hello, my name is Miss Sophia O'Neill, and I reside in Eagle River. I rent an apartment that I have not been able to steadily live in. Lack of dependable heat, proper water, it's one thing after another. The ceilings leak throughout, bailing, crossed pipes, contaminated water, affects the drinking water because sludge from other parts of the building get into the pipes. And then there's the noise. So why complain and endure? It's called the will, the hope for change in circumstances. I continue to pay rent on an apartment that is not assisted, that is plagued with problems, because we all know housing is sparse and you can't give up one place without having another. So I endure. I mediate, I negotiate with the landlord, and this has gone on for almost 2 years. Things get fixed, but the building is in bad disrepair. The job I have now only covers the rent for my apartment plus my storage, which is necessary due to the conditions of the apartment. The job I have covers my food and very basics and a place to live. However, this is temporary. It was thought I could transition with an addition being done at my work. However, the owners have all along been pending a sale of property with dates and everything askew constantly. So in lieu of all that, I held on to this apartment in disarray as my security, even beyond its repair. It's a day-to-day. Now, my situation has yet changed again. I am told the addition where I work will not happen anytime soon due to financial needs and the needs of renting perhaps the space that I currently occupy. I am placed firmly in uncertainty ever since May. All the time I paid rent to my apartment while not being able to regularly occupy that which I paid rent, waiting for heat, plumbing to be fixed. Luckily, having that job covered me and thinking in time, a new place to live too. Now, all of this was a working project and a working plan, only to be faced yet again with uncertainty again. A main problem for a renter too is a lack of mail receivable apartments, which mine is not the only one, and the lack of a consistent address. Well, this is required for all my future employment prospects. Despite how I try, the very real circumstances that we all face in Alaska is why people fail. It's why they leave. And despite my fidelity to what brought me here, and trust me, I still have great fidelity to it, the circumstances one must overcome could become unbearable, even for a seemingly unbreakable spirit. All aspects of how one becomes one without a home, almost, please.
You can go ahead and finish.
Okay, thank you. All aspects of how one becomes one without a home. Therefore, homelessness, the definition that is used, is actually far too narrow. That is what plagues us all, people and services alike. I thank you for your attention and my opportunity to speak and finish.
Thank
I
you.
feel respected.
Thank you for
All
your
right.
testimony. Appreciate it. Okay. Anybody else would like to speak today? Nope. Okay. All right. Thanks everybody for being here. Have a great day. This meeting is adjourned.